Hello, everyone. My name is Tiffany Obai. I'm the contact person for KEPhSA this year, and I officially welcome you to our webinar today. We will begin in 10 or so minutes, so let's be patient as we wait for the rest of the participants as well as our speakers to join us. But thank you for coming, and I hope you enjoy the session. Okay, I can start. For those who are not here earlier, my name is Tiffany Obai. I am the contact person for KEPhSA Kenya this year, and I am delighted to have all of you here for our first webinar as the executive committee. I will allow the other members of the EXCO to also introduce themselves. So, who will I start with? Okay, Brian, I see you unmuted. Go ahead.
Ooh. Hi everyone, this is Brian Anduso. In KEPhSA, I happen to be the Secretary General and Manyala, you can say a word.
Oh, yes. Good afternoon, everyone. I hope you can all hear me. Yes, my name is Silvanus Manyala from the University of Nairobi. I am the Media and Publications Officer for KEPhSA.
Eric, you can go ahead.
Hi everyone, my name is Eric Musia. I am the Organizing Secretary for KEPhSA.
Vicky?
Good evening, everyone. I am Vicky Njuguna. I am the SEO at KEPhSA, and I really appreciate you all for attending this webinar today, and I hope that we'll all learn something. Thank you.
Okay, then Dr. Lokeno can say a word. Then we'll have Dr. Bob also saying a word. Then we can allow the meeting to start after that. Dr. Lokeno, you can introduce yourself.
Thank you, Brian. My name is Dr. Lokeno. First of all, let me begin by saying hello to everyone. I am very much delighted to be part of this meeting today, and I look forward to an interactive session and an engaging one for that matter. Hopefully by the end of it all, we shall all have learned a thing or two. Thank you.
So good afternoon, everybody. Thank you so much, KEPhSA and the team, especially the officials, for welcoming us to be here. My name is Dr. Bob Agwata, and I work at the Division of National Malaria Program, previously known as the Division of National Malaria Control Program. I am the Unity Manager for Policy Planning and the Global Fund. Initially, I used to work in HIV, where I was for 4 years. And I think that informed the decision by the officials to invite me to speak about HIV. I am actually 3 months old in the Division of Malaria Program. And I think I can say I'm fresh from HIV, and therefore I hope we'll have this important interactive session. So I'm also equally humbled, as my colleague Dr. Luken has mentioned, that amongst all the people, you gave us the opportunity to be able to address this important forum of young and upcoming pharmacists in this country. Thank you.
Okay then, thank you to both our speakers for making themselves available and giving us their time this afternoon. And I guess we can begin with a short prayer before we go right in to the meeting. So let us pray. Thank you, God, for this day. Thank you for your protection. As we begin this meeting, we ask that you may be with us, guide us, and may it be successful. For we pray in Jesus' name, amen. Okay then, so as they have introduced themselves, we have Dr. Bob Agwata, who is a clinical pharmacist, and as he has mentioned, he is also a HIV/AIDS management specialist. And we also have Dr. Lokeno with us, and he is a senior pharmacist who works at the Samburu County and Referral Hospital. And he's also an advocate for good governance in health. So we are delighted to have both of them here with us to guide us in this session. And as we all know, our session today is titled HIV/AIDS in the COVID-19 era, and it's focusing on the role of pharmacists and us as future pharmacists in the management of viral pandemics. If you all didn't know, COVID-19 is not the first pandemic we have had. HIV is a pandemic as well, and it has been with us for a while now. And we know so far, while we are able to manage HIV, it doesn't have a cure. And COVID-19 sprang up at the end of last year and has been with us throughout this year and has driven us into a new normal. So as the EXCO, we decided to look at the two pandemics that we have and how they tie in, especially when it comes to the management of COVID patients who also have HIV. So I hope we will all have a good meeting as we go ahead. And I think we can jump right in to Dr. Bob's presentation on HIV and AIDS. Welcome, everyone.
So thank you. Can you hear me? I want to share my screen. I don't know whether it's sharing.
We can hear you, sir, and it was sharing. You were fine. You can just go ahead and try it again.
Very well. So thank you once more for this opportunity, for welcoming me here. And I think something that your convener mentioned was about my qualifications. Yes, indeed, I have a master's in clinical pharmacy, and I've specialized in pediatric medicine and oncology medicine. But I think, as you can see from screen one there, from the first slide, you can see that I do nothing now regarding the clinical pharmacy or the practice of oncology or pediatric medicine. I did that a while ago, I think 5 years back when I was in Coast General Hospital, where I was the chief pharmacist. But thereafter, I think I digressed, if I can use that word on a positive way. Now I do something very different. I look at policy planning, and I look at the Global Fund and the donor funding in general, and how it is managed in terms of ensuring that our response to the HIV, TB, and malaria is well taken care of. So I've been now a Global Fund manager for 3 years, 2 of which has been, 2.5 has been in HIV, and 1 has been in malaria. Not really 1, a few months now in malaria. But before I became a Global Fund manager, I worked in HIV logistics, where I was dealing with all the HIV commodities, specifically ensuring that the facilities and our clients are receiving the ARVs. And I worked there for 1.5 years before then I moved to the Global Fund. Now, I think at the last slide, I'll mention something about that introduction, but I think for now, I'll keep it as such. So I think I'll request, if I'll be allowed, to be able to look at both HIV and COVID as a one presentation. Then we can have all the concerns and questions raised for the sake of time, because I know we can't spend so much time, and because I know my colleague, Dr. Lokeno, will also be presenting. So I request that humbly I'm allowed to do that, if that is okay. Is that okay?
Yes, sir. Go ahead.
All right, thank you. So I have outlined my presentation to look at briefly the history of HIV and AIDS. Then we will focus more on Kenyan response to HIV. Then we will look at what are the current structures within the Ministry of Health that deal with the HIV. I look at the current programs or sections under HIV which deal with the management. Then, of course, being scientist, I look at the biomedical advancements which have been done. I look at the vaccine development update, and of course, we look at the ARV resistance and toxicity. Now, allow me, there are things which I have avoided, and one of the things I've avoided is this to be a purely scientific presentation, but rather have something that is beyond the science, beyond the drug, beyond the management, beyond those things that all of you can be able to look in a textbook or in, you can be taught. I want to look for it in the context of how, as a country, where are we? Of course, I'll mention a few things, but I'm not going to go to the details, like as if I'm teaching you the actual management, like if I'll be doing a ward round, or we're in a hospital, or we're in a pharmacy. So I think when I had a discussion with one of your vision, that is Brian, I think we had an agreement, and that's why I've structured my presentation to look like that. So I think all of us know what HIV is. We know it is a human immunodeficiency virus. That's an acronym for HIV. And we know what AIDS is, of course. That's an acquired immunodeficiency syndrome, which means you acquire an immunodeficiency. The deficiency of the immunity is acquired. It's not something that you are born with. And the syndrome means the many diseases that can come and attack you once that immunity is compromised. So AIDS as a disease was first clinically observed in 1981 in the USA. And the first people to be observed to have AIDS were the injecting drug users. the people use heroin, the people use cocaine, and all these injectable drugs. And the second class of people that were seen to be having these AIDS as a disease were homosexuals, or what we call gay men. And actually, these two groups, there was a third group which I'll mention later a bit, but these were the first two groups of people among whom HIV or AIDS was reported, AIDS as a disease. So the reason why it was called AIDS then, because they observed that these people are having an immunodeficiency, and then these people are, this immunity is not something that they were born with. It seems that it's an immunity which has been caused by something. And of course, that triggered the investigation. So, doctors who are looking at these people was that this, sorry for the disturbance, hear me now. So there was an observation that these people were suffering from a disease we call Pneumocystis carinii pneumonia, or what we call PCP, which is a very rare opportunistic infection, and it occurs with the people who have their immunity is compromised. So on top of this disease, again, they observed that they were having a rare skin cancer we call Kaposi sarcoma. And actually, because of these two diseases, the CDC now was forced to start looking at what's really happening. And they formed a task force that was going to look out and see what is this that is happening. So the first name that ever was given to the disease by the CDC, Center for Disease Control for America, and of course we know now it is everywhere in the world. The first name they gave us was GRID. And the meaning of the word GRID was gay-related immune deficiency. So you can see how this disease was highly individualized. So it was limited and restricted to the gay people. So that's why it was called GRID. But then, after singling out that the disease was common among also other groups like the Haitians, the people from Haiti, the homosexuals, the hemophiliacs, and the heroin users, they changed the name to, they called it the 4H disease. So whoever who suffered from this disease, they could say he suffered from the 4H diseases. Now, you can see it started from gay-related deficiency, which was a common thought that if you are gay and probably you have this disease, it is something that is only for the gay. Unfortunately, this changed, and you can see more and more groups came in. Now, later, as it was discovered, the disease was not only limited to gay people and drug users, so the name 4H or the GRID was found to be a name that is not applicable. It was misleading, even as they discovered more people in the heterosexual world who were also having AIDS. And therefore, the word AIDS was officially introduced in 1982 to be able to cover for the other groups of people that they discovered that also were suffering from the disease. So now, of course, once you find this deficiency, the most logical thing to do is to investigate. So in 1982-83, two groups, one led by Dr. Robert Gallo and another one led by Dr. Luc Montagnier, Dr. Gallo from the US and Dr. Luc was from the French Republic or from France. So they started finding out what is this that is really making people to have AIDS. And for Dr. Gallo, the virus he discovered, he named it a human T lymphotropic virus, or HTLV. And for Dr. Luc, the virus he discovered, he named it lymphadenopathic associated virus. So each of them said that probably my virus is what causes, the other one said my virus is what causes. So there was a controversy, and all of you can be able to check this out. But by 1986, when now independent other people came in to do what we call validation and look at the virus, they discovered that the virus was basically the same virus. So that's why in 1986, it was agreed that the virus should be named as the human immunodeficiency virus, or the HIV. So we all know the science about it, that this virus is very unique. When it is transmitted to you, it comes as a single strand RNA genome. And once it reaches to your system and it gets to the target cell, it has actually reverse transcribed, all right, by a reverse transcriptase enzyme. And then it forms a double-stranded DNA. And this one is what actually gets integrated into your cellular DNA, encoded by an integrase, which integrates it within your DNA, which then starts to order the production of the very many viruses that that we see now, which are transmitted. And of course, we know what it does. It targets the CD4 cells, which are soldiers, or which are actually responsible for your immunity. And once your immunity is compromised, what actually becomes a problem is not the virus, but the host of the diseases that attack you. And thereafter, those diseases now are the ones that can cause death. So I think I can stop with the science there, and kindly allow me, as we discussed, I want to look at what happened when this virus happened to go to the world. Now, I've told you that it was discovered in the USA and among specific groups of people, and then later people discovered that this thing is not only restricted to specific people, but it is something that is for everybody. So what happened next is, before we even could discuss about this thing, our first case was diagnosed in Kenya in 1984. And when this case was discovered, based on the information we had by then, and there was no substantive cure, and anybody who had HIV, for sure it was a death sentence. And of course, with an attitude that this disease is probably for gay people, for prostitutes, for drug users. Of course, it was deemed as a disease for sinners and a disease and a killer disease. And I think in this group, most likely some of you are not yet born. And I think one of the things that happened is the government really was not very prepared for this emergency. And because at first when this happened, it was very rare disease. And really people did not, they thought it was far off. So people in the village were very comfortable, they were okay. And the first place that was discovered to be a hotspot was Thika. Now, Thika used to have a big size of plantation, and there was a lot of sexual activities there, especially for prostitution, and these female sex workers were there. And it was discovered that there were a lot of people who were actually suffering from this HIV. So now, later a bit, fast forward to 1986-87, the demographics changed, and the Luo as a community, the Luo people, were the most affected tribe in the country when the numbers were being looked at. And also it was discovered at that time that the people worked in the what we used to call the posta and telecommunication. Actually, they were the most affected in terms of government institutions in those days. So it became clear that actually there was a problem with the Luo people as a tribe, and also for government workers, the people in posta. And actually, I want us to mark that. Let's remember, I'll later come to discuss about what was the reason why the Luos and the postal workers were the most affected those days. But we know as we talk now, HIV is no longer restricted to one specific tribe. We can be able to say that it is everywhere. So what was the response to our government? Our disease is here, and you don't know what to do. So what do? There's no cure, it's killing your people. So the first thing the government did was to put out very serious warning about HIV, especially in media. And it put very serious and scary adverts showing bony people as a consequence of HIV, with the keywords being there's no cure, with keywords that if you get it, you die. And I think, I don't know if there's anybody here who knows, there is a song that used to be sung, which used to say, ukimwi hatari kwa maisha yako, chungana na ukimwi. And you know, that song. So for some of us growing that time, I remember we used to associate HIV with death, and we used to associate it with the very scary things. So that was the response that the government had at that time, because they had nothing to do. It's only to warn people to be careful, and because it was predominantly known to be spread through either sexual work or through sexuality, it actually led to that kind of response by the government. Now, In 1987, after the government realized that there is indeed a problem, the National AIDS and STI Control Program was established, and their mandate was indeed to spearhead the HIV response in the country. Now, as years went by 2000, that is 3 years later, apart from malaria, HIV/AIDS accounted for in the country, which means a lot of deaths were occurring because of HIV/AIDS. So now the government being in cases, you bear with me, I beg for your indulgence. Some people are trying to call and I'm online, so kindly bear with me. So, as I was saying, the government was pushed by, there was high stigma because initially they were unaware, they didn't know about, they didn't have much understanding of the disease. There was very high stigma, and even those people used to die of HIV. They used to be, their coffins used to be wrapped with a black polythene paper, and with the population denial, still believing that probably their loved ones have died not because of HIV/AIDS. They thought that they have died of, of witchcraft, and the high mortality of the disease. By the year 2000, the former president, who was President Daniel Moi, the late, was forced to declare HIV as a national disaster. Now, there's a reason why that disease was declared a national disaster, because it reached a point that every single day we used to lose more than 500 people to HIV. 500 people to HIV every single day. So I want you to imagine if there were no interventions, how many people by now could have died? Quite a lot. So once HIV was declared by the president as a national disaster, now the United States government, through what we call USAID, started to put quite substantive amount of money to deal with the HIV, or to take the war with the HIV. And the government also was able now to see that this is a serious problem. At the same time, the Global Fund was formed by several governments who felt that the war on HIV needed all countries to participate, lest it becomes a world pandemic, and resources were mobilized on the same since then. And as Kenya, we are a part of the beneficiaries of the Global Funds and the USAID funding. So this has been the response this was the response by the government in terms of when HIV landed in our country. So now, within the ministry, where is the HIV program anchored? Now, I mentioned that NASCOP was established in 1987, and their main objective was to lead the war against HIV. Now, together with the other two killer diseases, one of it being tuberculosis and malaria, which I mentioned earlier, they form what we refer to as the National Strategic Health Programs that fall under the Directorate of Preventive and Promotive Health. So there's a reason these programs are called National Strategic Programs. It's because if you look at TB, HIV, and malaria, they form the biggest burden of the disease in this country, and they spend the highest resources. Currently, we spend over 50 billion shillings for HIV alone. We spend over 30 billion shillings for TB and over 35 billion shillings for malaria. So if you look at that budget, it is a huge budget. And the problem with these diseases, they are contagious, in the sense not really that high contagious, but let me say they are infectious diseases, and they move from person to person. And a disease like HIV is unique because once you get HIV and you can't treat it, you will only manage it for the rest of your life. And every day when we have new people coming in, it means the burden increases. And that's why it's important that measures that are appropriate are put in place to make sure that we don't add more people to this net. Because as more people come, it is an expense that becomes permanent until this person dies. Now, the program is managed and coordinated under the national government, that is the HIV program, malaria and TB, due to the significance in terms of disease burden and the global bearing. We are not only responsible as a country, but also we are global citizens. And therefore, what we do as a country for these three diseases bears a consequence to the rest of the world. If you don't control your HIV, definitely it will spread to other people outside. And this has been one of the strategies, even for other governments like the US, where they want to make sure that they control this pandemic here in this country before it goes elsewhere out. And that's why they fund the programs here to make sure that actually we are able to control the disease here. So the response is supposed to be highly focused and time-bound in that by a specific period they should. So why these strategic programs are still under national government. And everybody just about this disease. But if you have a centralized response team, it makes sure that we are able to coordinate this response nationwide and be able to respond to the world. And the world holds us accountable if we are making steps, first because they have made substantial investments, and secondly, they hold us because they know that if we don't succeed, then also as a world, they're not succeeding. And the country has set a target for these three diseases. By the year 2030, we should not be having a problem of HIV, a problem of TB, or a problem with malaria. Now, that's just a table on how we report. So you can see the three diseases are down there. There is the division of TB, division of malaria, division of HIV, which we call Division of National AIDS and STI Control Program, who report the Department of National Strategic Health Programs. And above them is the Directorate of Preventive Promotive Health. And above the Directorate, of course, is now the Director General for Health at the Ministry of Health. And below these divisions actually is basically the county governments and other partners who support the war on these three diseases. Now, what are the current sections and the HIV response specifically? Now, the HIV interventions, much as it's a disease, we have found out that there are other factors that contribute to this disease, and the response has been classified into three. The first one is what we call the structural interventions, which are the systems that enable the delivery of services like the human resource, the health facilities, the income to families and vulnerable groups that make sure that probably the girls remain in school, that make sure that families are supported to have an income, so that because we know that poverty itself is a contributing risk factor for HIV. And also the distribution channels like those we use to deliver condoms to hotels, to other vulnerable populations and such. So these are what we call the structural interventions. The other group of interventions is what we call the behavioral interventions. So these are interventions that target those behaviors that have been proven to fuel the pandemic. Like for instance, we know very well that sex without use of condom is a risk factor. So if we educate people to change this behavior, actually it is an indication, or it has been proven that that change of behavior substantively reduces the risk for HIV. Then of course we have things like intergenerational sex between very old men and very young girls. Commercial sex, of course, we know that these are things that fuel, and therefore we try to bring interventions which will change this behavior. Like for commercial sex workers, we try to bring other alternative sources of income generating activities, which will change them from actually engaging in commercial sex. Then of course, finally, we have what we call the biomedical interventions. And these biomedical interventions we know are the actual interventions that target the virus itself. And basically things like drugs, like vaccines, and another thing that look at the HIV as a disease are lumped under the biomedical interventions. So now, we have different sections in the HIV response. We have looked at the broad aspects of intervention, but we want to look specifically, if you look now under now the HIV program, what are some of the different interventions that we carry out? The first one is what we call the prevention of mother-to-child transmission of HIV, which we call as PMTCT. The second one is what we call the HIV care and treatment. The third is voluntary male medical circumcision, or what we call as VMMC. The fourth one is the key population interventions. And of course, the last one, but not the least, and also broadly, is the adolescents, young people, and the young women intervention. So I'll just briefly look through one by one, then we'll be able to move to the next section. So for PMTCT, it is considered to be one of the greatest milestones that ever made in the war against HIV. The very dream that our young girls and the women who are bearing children who are HIV positive can have children, and through very good interventions, these children can turn out to be negative, was the biggest news that ever came to this country and the world. Initially, all women who were HIV positive, when they tried to give birth to children, these children were HIV positive. Most of them, almost 90%, were HIV positive. And most of these children ended up dying before they could celebrate their 5th birthday. So actually the ability for us to have interventions that could prevent children who are being born to be HIV negative was a big thing. And therefore, this became a substantive section which actually a lot of institutions invested in, because it gave hopes to women and to people who are HIV that they can get children and have families. So currently, all pregnant women who are HIV positive are required to be on highly active antiretroviral therapy, or what we call HART. So it has been proven. We have been making milestones, and I don't want to go to the history because it's big. We started with a single drug. We came to a concoction of drugs until now. We now know we started with giving during pregnancy, then you stop. Again, now we have, through science and through many research, now we have actually come to the point that all pregnant women should be on HART or on ART, antiretroviral therapy. And once they start, it should be continuous. And actually, because of that, we have seen that our MTCT rate has reduced to around 8%. Of course, there were some variations between 8 and 10, but you can imagine that out of 100 children who are born, it's only that only 10 can get HIV. That's good news. But our aim is for us to see that we have eliminated mother-to-child transmission, like Cuba has done. The target is for us to have it below 5 and sustain it for 5 years. Then we can be able to say that we actually have actually eliminated mother-to-child transmission of HIV. So we used to have more than 20,000 cases, but annually these days we have less than 6,000 cases. Now, this gave young girls and mothers of childbearing age living with HIV the hope to have families, and I think I mentioned that. So currently, this program is something that has a lot of focus, and the slogan really is no child, no HIV child mother should be born with HIV in this country. No child should be born with HIV in this country. And I hope that with the next generation of young healthcare workers, where you form part of the team, I think this should be something that we sustain and make sure that we succeed in doing so. The next one is care and treatment. Of course, in the year 2002, the antiretroviral drugs were introduced and the age of treatment was born. It has also been a journey. Some of the veterans in HIV in this country, like Professor Loach, they can tell that they even tried to use hydroxyurea in treatment of HIV, and it was not working. A concoction of drugs, everything was tried, and it was not working. So the good news is that we have moved and we have really progressed from using multiple drugs, from using so many tablets. I remember when I started practicing in the hospital in the year 2005, I remember that time we were using almost 10 drugs, and they were being taken twice. So at least the bill burden was high. And by that time, mostly people were coming when it was late. So you are given anti-TB drugs, you're having Septrin, and you are given the ARVs. They were, I think that time, 3 drugs in the morning, in the evening. So the bill burden was really too much. But looking now, today, we can see that it's one of the milestones that I'm going to discuss about that has been made in terms of how far we have come in the care and treatment of HIV. So currently we have 1.1 million people living with HIV who have been put on HART, and this is due to government efforts the support from Global Fund and the USAID, and also, of course, from WHO. So what has this one done, basically? What it has done is that it has averted more than 450,000 deaths, which could have occurred if there were no any interventions of ART. We know ART is not a cure, but we know that it reduces the virus, it minimizes its multiplication, and therefore the body is able to have its immunity. And when the body has its immunity, it is able to fight other diseases that actually will take opportunity of an immunocompromised person. Therefore, the quality of life has been improved of people who are living with HIV. The fact that people are not sickly, they are healthy, they are okay, they are able to go to jobs, they are able to do work, basically gives the quality of life better, and some of them who are family people, they're able to take care of their families. And also, orphans have been reduced. We know that one of the biggest burden was orphans, and these orphans actually were because parents were dying early and they were leaving their children without any kind of care or of anything. So actually the ART introduction, and also this is also protective in the sense, if you are taking your ARVs properly, all of you know that your viral load is reduced substantially, I mean. And once this viral load is reduced, it means even if you are having unprotected sex, it reduces the chances of you either transmitting or getting HIV. Now, I'm talking to people who are professionals. I'm talking to the doctors of tomorrow. Please don't go and tell other people that if you are taking ARVs properly and you are very suppressed, you cannot transmit HIV. I hope you are hearing me, colleagues. I've mentioned to people who are educated that you and I know that if your viral load is undetectable, it means it's not even there to be spread in the first place. And therefore, it is important that we make sure that we reduce the viral loads by making sure that our people are taking their drugs properly and they are adhering to that. And as a result, we can be able to be sure that we can prevent the spread of HIV. So the care and treatment component is not only for the treatment, but also it is for the prevention of, it's also preventative in the sense that it can prevent the further spread of HIV. Now, I come to another area which is called the VMMC. The VMMC is an acronym for Voluntary Male Medical Circumcision. Now, in our country, we know that there are some communities which traditionally don't circumcise their male. And one of the communities, of course, are my neighbors, the Luo and the Turkanas on the other side of northeastern, I mean of west, I don't know whether that is western part of Kenya or northern Kenya. So these two communities don't traditionally circumcise their male, but that has changed from the year 2014. That has changed. Now, as mentioned earlier, I said about the Luo community that was severely affected by HIV. And actually, there are many factors which have contributed. But one of the factors that people have been able to establish was that it was discovered that if you are not circumcised as a male, then the risk of you getting HIV is more than a colleague or another male who is circumcised. So this was a big risk factor, especially for the Luo community, because most of the Luo communities were not circumcised in their male traditionally in those days. So scientifically now, and I know you guys are scientists, you can go and Google, it has been proven that male who are circumcised are likely to get protection of up to 60% from having unprotected sex compared to those who are not circumcised. That is quite a huge chance, a huge protection gap, and we cannot be able to afford to lose it. And that's why you saw in the year from 2015 to 2017, even politicians, the leadership from the non-circumcising communities have been brought on board to discuss the issue about male medical circumcision. And specifically, we wanted to be voluntary because we know culturally it is something that people don't practice. So you can't go there and start forcing your way. And I can tell you that as we discuss, there is a whole generation of young men, especially young men now who are in high school and high school. Most of these young men actually have been circumcised, which actually for us, we think that it's going to reduce the risk very substantial. So it is voluntary, as I mentioned, and it's targeting traditional non-circumcising communities, the Turkanas and the Luos and another people. The vision is that by 2030, all males should be circumcised, and we have moved now even from voluntary medical, now we are doing what we call the infant circumcision for very young children, so that as they grow up, they are already circumcised. So that's what we call the voluntary medical circumcision. Now, for communities like mine, the Kisi people, and other communities who traditionally circumcised, I think for them, the risk is not a lot. And I'm happy that this is very voluntary. I want to remember when I was personally circumcised, you know, there was nothing voluntary those days. We were escorted to a bush, and we were being waited there with some traditional circumciser. And you know, it was deemed that if you cry, it is not brave enough. And really, we were circumcised very involuntarily. And I can tell it was not a good exercise. But I think I'm happy that these days, there is indeed voluntary medical circumcision. And if there's anybody here who's listening, who's not a male, who's not circumcised, please go get this good. These days, it's better. There is medication. It's done nicely. You are well, you know, there is a lot of, how do we call this process? There's something that I remember it and come to it. So you don't even feel the pain. Anesthesia, yeah, there is good anesthesia. You don't even feel the pain, you know, when you're being circumcised. Those days, some of us, it was painful exercise. You were being slaughtered like a chicken, eh? And that's why for some communities, if you abuse somebody who's circumcised and you abuse him the name of uncircumcised, I think you can really get it very rough, because the association of what circumcision meant for some of those communities. So I think that is one intervention that we have scientific evidence that actually we've well implemented. It will substantially reduce the risk of spread of HIV among especially men. Now, there's what we call the key populations interventions. Now, the word key population was a term that was coined because, number one, it was discovered that there's a specific group of people who actually, by being existent, they are the reservoirs for the disease, and also they are fueling the spread of the disease. And that's why actually this word key population was coined for these very specific groups of people. And these groups include, but not limited to, the female sex workers, the people with injecting drug use who use cocaine and such like things, the male who are having sex with men. These three groups, and also there are others like the transgenders whose role has not been clearly defined. It was discovered that, number one, if you remember, the first group of people where we discovered HIV were gay men, or men having sex with men. And then also with the injecting drug users. And therefore it came to the other populations because of heterosexuality, the non-good use of needles. Those days, you know, people were sharing needles and all these things, and female sex workers where there was no protection. And we have discovered that interventions that target these specific groups actually substantially reduce the possibility of this pandemic being fueled. And let me give you an example. Like female sex workers, we know very well that the female sex trade in the world, not even in Kenya, is something that is so huge. And we know that some of the factors that fuel it is poverty, all right, unemployment and all these things. And that's why actually I think it's important that actually as a country, we need to make sure that we provide employment for our people. So I wanted to imagine what happened during female sex work. These people are very vulnerable in the sense they are poor. Some people even force them to have sex without a condom, all right? They force them, or some even don't care about using a condom because as long as they are being paid handsomely. So these people, if we are able to put interventions that target them, actually there is evidence that we are going to reduce the spread of HIV in this country. So the interventions are many, but I want to say that some of them are like use of condom, lubricants for men having sex with men, the methadone program for rehabilitating these people who inject with the drugs, decriminalization of groups, especially in health seeking circumstances. You know very well in Kenya that homosexuality is a criminal, female work is criminal, and therefore, if we extend this criminalization even to health seeking, it becomes a problem. Why am I saying so? If in a hospital somebody knows that if I am a gay man, or if I am somebody who injects with drug, I show up in a hospital, I will be discriminated against receiving the service, or I'll be used there, people can report me to be caught, then people will shy off from seeking the health services which are necessary. For instance, and then what will happen? You'll find people, if they don't seek the services earlier, some people who are especially have HIV, they will continue spreading the HIV without using the proper medication, and that becomes a risk for all of us. Then of course, testing and health seeking behavior is very important, but there are many, I cannot mention all of them here. I just want to say that these are some of the interventions we do that make sure that we either prevent or we manage those people or we get to have HIV. So our vision is really that we should restrict the HIV to this specific. Actually, people are saying if we are able to restrict HIV to this specific group, it will be easier than when they go to the general population, where it becomes a bit hard even to do it. So that's why we have specific interventions that target the key populations of this country. So what about adolescents and young people? So statistics show that HIV is on the rise among the adolescents, young people, and especially women. Now, we know if you look at our statistics that the HIV prevalence in our country is around 4.8%. It has come down. But among women, it is 5.8, and among men, it is 3.1. And of course, we know why. A woman is anatomy, physiology. You people understand that. Of course, they are the recipient of semen. And as such, because they receive this semen and it stays in their body, it actually increases the chances and the risk of getting HIV. And that's why we see men. And the women are the most vulnerable populations of our society, being a patriarchal society. But also, if you look at now adolescents and young people, we are seeing a rise of cases. One of it is, and you guys, I know most of you are in campus. One of the things we see in campus is that you guys fear pregnancy more than even HIV. I don't know why. You know, those are very reverse roles. I think sometimes it's because some of you have not understood the absolute consequence of HIV even compared to having a baby. But I think because of that, young people would rather they have HIV but not get pregnant. And such kind of attitude and probably lack of civic education has actually led to the spread of HIV. Then secondly, the intergenerational sex is also a contributing factor. One of the things we are seeing nowadays is the increase of sponsors and sugar mummies, and because of poverty. And you know, nowadays, unlike when some of us went to college, where we were able to be taken care of by the universities, people were given money, the university could provide a hostel for you, they could provide meals for you, even it could be at a minimum fee. Nowadays, we see trends whereby young people are supposed to go hire a house, they buy for their own food. Food is expensive, life is expensive, and also some young people's lifestyle has changed, so they will do anything to get money. And actually, we are foreseeing that intergenerational sex where people like us now who are employed and are working and who can afford to pay rent for some girl somewhere in KU or in JKUAT or in University of Nairobi, then you are able to, to get the favors, the sexual favors that you need. But as a nation, we are realizing the negative impact of that, all right? And we are trying to make sure that we reduce the factors. And you know that those factors, as I mentioned, like behavior, the vulnerability, the poverty, and sometimes even ignorance, we are trying to target them so that we can educate UEP, especially young people, to make sure that much as you want to have sex and those other things, there's need for you to have safe sex. So the interventions in that area, in this category, include sex education, especially civic, the structured intervention that ensure the girls are in school, especially in communities where there is high poverty, behavioral interventions like condom use, and of course, abstinence is very important. You know, abstinence was very important until some people started thinking that abstinence is only for church. it's for church, but it's not actually. Abstinence is good if you guys are not married. Why can't you wait and you get married when you are big enough? If you can't, then have safe sex. Of course, now I want to look at the biomedical interventions, which are very many. But being a disease, of course, biomedical interventions account for the biggest and most proved and effective intervention. So we have both care and treatment that range from nutritional care and even to the use of ARVs themselves. So it's not just once. If somebody is not having food in his stomach, is not nutritional being taken care of, using of drug will only increase the side effects, will only increase the toxicity, and will not have the intended effect. So the many classes of ARVs, we know them. So I'm going to be very broad here. Of course, we have the nucleoside advanced transcription inhibitors, which we call the NRITI. We have the non-nucleoside advanced transcription inhibitors, which we call the tribonukes. We have the protease inhibitors, the integrase inhibitors, among of ARVs that actually we use for the management of ARVs. Now, the other intervention for this, I think the best advancement we've made is the reduction of the bill burden and the reduction of the frequency of administration. Now, as I mentioned, when I started practicing in 2005, I used to dispense boxes. Somebody had to come literally with a paper bag. Those days, the paper bags had not been banned. You have to come with a paper bag to carry your drugs for the whole month or 2 months, a whole paper bag. And I'm sure I'll put more than 10 boxes in that paper bag, plus other things on the dispenser envelope. So you used to find that somebody used to take more than 10 drugs at a go, tablets, 10 of them. I want you to imagine that bill burden. And they are not small tablets like I think the smallest tablet is it Nalapril or is it Goxin? I don't know. It's a long time I was in the facility. But I want you to imagine they are big, the size of paracetamol and above, and you are taking 10 of them. How bad it was. TB, like 4 tablets at a go. HIV, like 5 tablets at a go. Then you add on top of that septrin. Then you add also for other opportunistic infections. It was very bad. But nowadays, as we are talking, we have reduced that to 1 tablet a day, at most 2. All right. We have had what we call the fixed dose combinations, which are very important. Now we combine all these drugs in 1 tablet, and actually you are able to take once. We even reduced the frequency because we have discovered more molecules which are better, which actually are proving to be more effective and less toxic compared to the drugs that we started with. Another thing we are talking about is PrEP, pre-exposure. We have what we call PEP, pre-exposure prophylaxis, but we have to call PrEP. PrEP is actually, PEP is post-exposure when you have done. PrEP is pre-exposure, which means post-exposure is when you have been exposed and then you are taking the drugs to be able to work on it. But pre is anticipated that I'm going to be exposed, so I'm going to take this drug. So the PrEP is something that we know we have a combination of 2 drugs, CDF and emtricitabine, which actually we give to you. You take their specific instructions, and I'm going to give a leakage. If you are anticipating to go and have unprotected sex. Now, for example, there are men who go to places like Thailand. You know, Thailand is a man's playground for sex. So if you are anticipating you're going to go to Thailand, the first thing you do is that you take this PrEP. You start 7 days before your first exposure. Then during that exposure of sex, you take every single day. And then after the exposure, you take 7 days consecutively after the last time of sex. And actually, scientists are saying that there is evidence that this can be able to prevent HIV infection. Therefore, there is no need nowadays, if you want to have HIV, you are going to have sex, why you cannot even take this simple measure of pre-exposure prophylaxis. Another thing that has been there, another advance which has been made by medical is the vaginal rings. There is a drug called the buffering, which actually there is a study, and they found out that this is something, a ring that you put in the vagina, which has this the buffering, and you put it 1 month and then you change it again because by that time it will have been exhausted. And they say up to 39% prevention of HIV acquisition. So currently it is under regulation review to see what can be done and to make it even better before it comes and becomes available in the market. Of course, there are implants where we say that we put you under skin, like the neuroplants we use for the reproductive health, right? For the reproductive health. So there are also implants, and one of the drugs that has been done research with is latravir, and still it's ongoing. They have not really finished on it, but still there are other steps that are being done so that they can see the efficacy of the same. Then of course we have the injectables, the monthly or longer than that, which is still under investigation. And all these things are being looked at to make sure that we have a more acceptable way of treatment and more choices for people. There are people who prefer, they rather have one injection per month or longer, and then they come back instead of taking everyday tablet. There are those who will want to have an implant inserted in their body, and then they'll be okay walking around. There are those who will want to have a vaginal ring to keep it there so that, you know, when they are having sex, they are protected. There are those who will want to be taking tablet daily and all these things. So these are some of the advances that have been made, and still others more are coming when we are looking at the biomedical interventions. So the one that is looking more plausible currently is the injectable. It's looking more promising, and the implant, whereby you'll be injected once a month instead of going for daily tablets or daily pills. So, but these are under investigation, and still there are no conclusions. And of course, when it comes to vaccine, which we consider the ultimate trophy for the war against HIV, there are many organizations currently who are researching on the same. But the most notable one, which I think all of you are aware, is the Mosaico vaccine research, which is currently under phase 3 trial in America, Africa, and in Europe for efficacy before they can say whether it can be rolled out. But there are other organizations which are in different levels of investigation for vaccine. So, and I think, in my view, this is an active area for future research for pharmacists, especially for vaccines. If somebody can come, you know, vaccine must not be only in one area. There are many, you can target many areas in a vaccine. You can even target a nucleoside, you can target an enzyme, you can target something. So let us not be restricted to what Mosaico are doing. If we have ability to investigate another area of coming up with a vaccine, I think as pharmacists and healthcare workers, this is somewhere that we can be able to focus. So I was told to mention about ARV resistance and toxicity briefly. So one of the problems we have with the HIV virus is its ability to mutate constantly and change. And because of mutations, this virus is able to develop resistance to very many drugs. And once you have resistance to drugs, what actually leads to is what you call treatment failure, where you are taking your drugs, but still with taking those drugs, the problem is that still your viral load continues to go high. You are still getting opportunistic infections. Your immunity is still being compromised. So one of the drugs that has been singled out was a drug like nevirapine, which is actually, I think it's a nucleoside reverse transcription inhibitor, and also drugs like stavudine, which we have long phased out. So these are some of the drugs we are seeing that there's resistance that the virus is developing towards them. Now, once you start experiencing the treatment failure, we start now moving from first line to second line to third line. And the higher the line you move, the more toxic the drugs and the less effective comparatively. So let nobody cheat you that when you're in third line, you are taking superior drugs. There are also a catch to those superior drugs. So the commonest reason for drug resistance, of course, is non-compliance, and there's no proper adherence. So if you are not compliant with your drugs, taking them the right time, the right dosage, likely the virus gets more bolder and bolder, and less exposure to the drug means that the virus becomes stronger and eventually becomes resistant. Another reason is reinfection. Some people, you find that, like we know, we have HIV type 1 and HIV type 2. So if you have HIV, it's important you continue practicing safe sex, because you can get somebody to reinfect you with another strain which is more resistant. For example, if somebody has been with HIV, is in third line, and you have just been infected, you are in first line. If you have unprotected sex, somebody can reinfect you with the resistant strain of the virus. And that's why we still educate our people to make sure that they play safe sex and they are actually protecting themselves while they're having sex. So, and for toxicity, I think I want to mention very quickly some of the toxicities now. And I want to make mention specific of third lines, which are very third line and second line. They are more toxic drugs. So some of the side effects we know, and I've just mentioned examples of drugs there, like lipodystrophy. Lipodystrophy is the unequal distribution of fats in your body. So you'll find that probably if you see some people who are HIV positive, their legs are very thin while their bust is big, their hips are huge, while their arms are very tiny. I wish I could show some photos here, but because I don't want to go specific. Now, these are topics that you can deal with specifically. So because of that, a drug, an example is default, which is stavudine, used to cause that. And this unequal distribution of fats is one of the side effects that was very uncomfortable for some people, because it used to make them have a very bad shape, especially for the female clients who are very sensitive. We have anemia, especially the bone marrow anemia, like the AZT, that is stavudine, has been known to cause that. High blood sugars or hyperglycemia, like for dolutegravir or DTG. We have the neurological ones, like bad dreams, like seeing other things, like KEPhSA was the common culprit for that, and still remains to be the common culprit. Then, of course, one of the side effects that initially was very bad and dangerous was the immune reconstitution syndrome, whereby because you are trying to take drugs and your immunity was so low, the body will react so bad that you become more sick and actually even die. Actually, some people died, but so people thought that by taking ARVs, you are going to die, but it's because of the immune reconstitution, where that the body is trying to reconstitute your immunity and the reaction takes. I think you guys can go read more about it in your books. Of course, there was rash, which was graded from 1 to 4 grades. There is severe and there was rare, the minor rash. But the common culprit there was the nevirapine. Then also there is possible teratogenicity. Teratogenic drugs are those that cause deformations in the fetus. So a drug like DTG, there were controversies before we introduced it some 2 years back, where people were saying that for women who are age bearing, they should not be given this drug. And the reason is they say they were causing some teratogenicity to these children. Evidence, we know about the spina bifida. There was some indication that it can be causing that, although it was a rare side effect. So these are just the main ones, but there are many more side effects and toxicities. And this is where as a pharmacist you come in. Even as you give these drugs and you are hoping they will produce the effect that you want, we should be on the lookout on the side effects and possibly mitigate them before they get worse, either by discontinuations or by sensitization. You know what sensitization is? You introduce drugs slowly, then as you go by. So I think that is all I say about HIV. So allow me to quickly now in the next 10 minutes to speak about COVID and HIV, because that was the relationship. Then I think we can be able to call it a presentation. So we know about COVID. I don't want to go because we have been told until it is tired. Everybody knows about COVID. We know that it's a disease which is caused by the coronavirus, and this coronavirus sometimes called SARS-CoV-2. There are other related viruses of the family. We know the beta coronavirus, delta coronavirus, and even the alpha coronavirus, where evidence is that this coronavirus belongs to one of those families. Now, it is thought that it is a virus that is naturally found on bats, especially the specific bat that is in China. And we know that the disease started in Wuhan, which is one of the provinces of China. There are, however, controversies whether this is a product of chimeric research. You know, the chimeric research is a controversial area whereby people look at something which is totally harmless and then they weaponize that and they make it harmful. The reason why there's a controversy is because people say the coronavirus in the bat has been there for centuries, and people have been eating, especially Chinese, they eat bats, they eat these things, and nobody has been infected because of that. Bites have been biting people, and therefore they were wondering, how comes this thing is now coming to be in prominence now? And the controversies, the people are presenting evidence of a conspiracy theory, whether this virus was weaponized. It used to be unharmful, but they weaponized it to become harmful. And even we know, even with HIV, that has been a problem, that there has been a chimeric research which was being done. And they say that probably the HIV virus was weaponized. The reason they say is, if you are saying that it was found in monkeys in Africa, how comes that we didn't see HIV in Africa? The first place we are seeing HIV is actually in the USA, where there are not even monkeys in the first place, where people don't even eat those monkeys. But I don't want to go to that controversy. Now that, yes, it might be true or it might not true, but what we want to do is how do we deal the problem as it is. So that's why we really don't encourage chimeric research. And I think, in my opinion, if this is true, it is very unfortunate that we have enough problems and somebody will just go and start weaponizing a virus that is harmless so that it can cause harm to humanity. It is an indication of how we have lost our morality and our standing as human beings. So, but that I said is controversial, that it is like that COVID indeed is as a result of a chimeric research. So we know the signs: high fever, dry cough, sneezing, tiredness. Now we have evidence of hyperglycemia, where people are actually having high sugars even if you don't have diabetes. There are some people diarrhea badly, all right? And of course, we know that there are other symptoms which vary from person to person, but these are the main dominant one. And we know the fever. Somebody was asking me, temperature mnachukua daktari, what is the temperature that you say is high? Some people you don't know when it will be high, but the temperature is from 37.3 and above is considered as high fever, from 37.3 and above. So the sneezing, the coughing, and sometimes you don't even produce any mucus. Tiredness, you just feel that you are so tired, you are fatigued, you don't feel like doing any activity. And of course, hyperglycemia, your sugars go high. And even some people are experiencing arrhythmias, but very few cases of such. So are HIV patients at increased risk of COVID? I think this is something that we want to let and we answer. I've said yes and no. I've said yes in the sense that those with advanced disease, especially HIV stage 4, HIV has 4 stages. There is the stage 1, which is asymptomatic, you don't show any signs. Stage 2, where it's mild. Stage 3, serious. Then stage 4, of course, is severe disease. Now, for those who have advanced disease, who are probably stage 3 and 4, where we start seeing some opportunistic infections, who have very low CD4 count, which is the cells that indicate your immunity strength, and very high viral loads, and are not on ART, are likely to be at higher risk, not only from COVID, but other diseases. All right. So that's why I'm saying yes, because HIV being a disease that weakens your immunity and opens up for other hosts of syndromes. Therefore, if you have all those combined together, then such kind of people indeed, they are vulnerable and they are at increased risk of getting the COVID-19. So also those with other comorbidities like hypertension, diabetes, apart from HIV, also are at an increased risk of getting COVID. And I'm saying no. The reason is, when we look at different studies, there has not been enough studies to give us evidence, and generally it is unknown if immunosuppression is a true factor risk for COVID, because even people who are okay are getting COVID anyway, because COVID is an airborne disease, kind of, we know how it spreads, and therefore that's why I'm saying no, you cannot say so. But yes, if there are a host of factors that we consider, not only for COVID, but even for other diseases. So can ARVs prevent COVID? That's a question I know most of you will say. So far there are 2 studies which have been done, which have been I can say peer reviewed by, and also have been put on the WHO website. And they say that they looked at a drug we call ropinavir, ritonavir, LPVR/R, and according to them, they suggest that, of course, there's some prevention of people getting COVID from this study. So the other study which was done among the 19 people living with HIV hospitals in the same ward of SARS patients, of whom 11 were on antiretroviral therapy or ART, did not get the COVID. But in conclusion, there is no substantive evidence on the same due to the sample size, the variability, and the intensity of exposure. This is still an area that will be considered to be looked on, whether really we can use ARVs for prophylaxis. So for more information, you can go to www.WHO.international for more information about these issues. What about treatment? Can we use ARV for treatment of COVID-19? So here we have many studies which have been done that suggest that patients infected with the virus, which causes COVID, which is coronavirus, and related coronavirus infection, that is the SARS-CoV and the MERS-CoV, had very good outcomes, with almost all cases recovering fully. So in some cases, patients were given an antiretroviral drug, which is ropinavir boosted with ritonavir. These studies were mostly carried out in HIV-negative individuals. But there were serious limitations to this study, which included the duration of time that the study was done, the dosing that is given, which was varied from place to place, and the extent of study, which means look at the number of people they used, which were not very many. So conclusively, we cannot say that we can use ARVs for treatment or ART for treatment of COVID patients. But from what we have, we can say that what was done and there were recoveries, and therefore it can be considered for that. But because of the limitations, more work is still going on to see whether we can use ARVs or ARTs for treatment of COVID-19. Still on the same website, you can find more the studies which have been done, and you guys can be able to look them for yourself. So how is COVID managed? So mostly we manage COVID asymptomatically, which means we look at the symptomatically, we look at the symptom, we treat it. If you have come with high fever, first thing we do is to make sure we lower your fever down. If you come that you are probably having high sugars, we reduce the sugars first. So mostly it is symptomatically. So we take care of the symptoms that you show or the specific problem that you have. Now, at some point, because of inflammation, people used to think that steroids are good, but most studies which have been done, they are saying that it is discouraged from using steroids unless it's very specific reason that only the steroids can be able to do it. There are ARVs, and I think we have discussed that. That's part of the people that you consider, especially the ropinavir, ritonavir, is high on the list. Then, of course, oxygen. We know that this disease affects lungs and oxygen supply. Oxygen seems to be still important, especially for patients who are in HDU, that's high dependence unit, or ICU unit. There are a lot of controversies with hydroxychloroquine, and I don't want to go about it. At some point, it was being touted as the drug of choice, but still the controversies readed it, and you know the controversies. But still, I think, well, I don't know. In Uganda, they have used it to some success, and all of you know you've heard about it. You can go and do more investigation on it. But it is one of the drugs that is considered for treatment. So basically, I cannot mention here. There are other things they mention about vitamin C. They say it has a good effect. There were people are taking, you know, things which have high content of vitamin C, like fruits and other things. But I think the big thing also, the immunity of anybody matters. And we all know that now COVID is targeting people with underlying conditions and the comorbidities. And that's why it's important that we make sure that our immunity is boosted. Now the vitamin C, we know very well, it boosts your immunity, eating of fruits, eating of vegetables, you know, all these things, they make your immunity better. So I think that's what I can say about management, but very specific management is based on case to case. And actually it is muted as that case is being discussed at that point. Then I think I want to mention about the role of a pharmacist for both HIV and COVID. Number one, you must form the frontline team that actually crafts and decides which regimens are to be given as case comes, as case per case basis, on the case by case basis. I mean, therefore, we should not be away. You should be in the front end of discussing, looking at the patients, what the patient is showing, what do you think will you recommend, and you should be there crafting that regimen, and if possible, even giving that regimen and monitoring the interactions and the possible toxicities of the regimen that you give. Then counseling, I'll put that counseling wide. I don't want to put drug only counseling. No, we should not be restricting ourselves to only drug counseling. We should be able to expand our horizons and do even other counseling apart from drug counseling, including public education. Who say that only public education should be done by nurses? Even you can do public education. It's a matter of reading. You are smart people. It's a matter of reading, understanding, and being able to do it. Then, of course, we need to be volunteers in making sure that we help where a hand is. We know very well that the country has not been employing healthcare workers for some time. Some places might be low. You are people who have more knowledge and who can be able to be led and be able to volunteer and help. Of course, research and development is something that you guys should think about. How do we end these pandemics and how do we end these viruses? This is an area that is open for scientists who are serious, and I think the pharmacists, with the knowledge we have of drugs, of molecules, we are best suited towards that area. And of course, policy change and implementation. People like us, we sit where we discuss about policy. What do we do given the evidence that we have been provided, given the trends? We sit down and discuss about the policy, whether we change it, and also how do we implement that policy effectively to have the desired outcomes. So that is the role of what we can do for HIV and COVID at this time as pharmacists. Then what is the future? I'm looking at the future for HIV and COVID, and of course there are three things I'm looking at. Number one, I'm looking at these diseases. Of course, the vaccine, as I mentioned. If we can be able to get the vaccine for these diseases, which is effective, I think it is something that we can do. Of course, we know what is happening in the US and UK. The vaccine is out. People have a lot of doubts about it because of the time it has taken to develop it. But I think what people don't understand is, if 10 years ago we were taking 10 years to develop a vaccine, you can't compare now with the technology that we have. 10 years ago, we didn't know what is even Facebook. We didn't even know what is 3D. Now we know about 3D and many other things. So the advances made in the world of technology can definitely shorten the time taken to do anything. We should not forget about that. However, some things remain a bit, some people are a bit traditional. They think that we should take the processes for us to be able to, slow processes to be able to establish the safety, which I agree to some extent, but also we should understand you cannot tell people that a vaccine takes 20 years to develop the way it was done for the influenza vaccine. We are in an era whereby we have more scientists, we have more advanced in technologies. We have even, for heaven's sake, machines that can tell you a molecule you develop and be able to say whether it will be toxic or will it be okay. Therefore, vaccination is something we are looking at. Already we have had America and Europe, they have started doing it, and we hope that probably it will come to our side. Then, of course, we want to have what we call epidemiological predictors and emergency prepared response. One of the things we should be better prepared epidemiologically is to be able to know what is likely to be a problem in this country, and to be able to predict it, and to be able to be prepared to see if it comes, what are we able to do? This becomes a multi-sectorial response. For healthcare workers, we have to make sure that are we prepared to deal with the pandemics? For the government, are we able to fund the response that is necessary? And therefore, this is why we need to be able to be a country that is able to look at a pandemic and be able to prepare. Remember, Obama was talking about a disease that can be airborne and dangerous, and they need to prepare for it. Unfortunately, when President Trump came, he said that is nothing. There's no disease like that, and you can see the devastation that it has. Therefore, as healthcare workers, we need to be prepared epidemiologically and be able to have predictors of severe diseases. And I think as a country, even we need to be prepared. What will happen if somebody drops an aerosol poison on us, a chemical weapon? Are we prepared to deal with such kind of eventualities? If we are not prepared, then I think it's time that we need to do that. So finally, I think I want to mention that for pharmacists, the future is big. But I wanted to mention here that I think you guys can see that the trends which are happening here in the government are not very good trends. you can see that people prefer hiring farm techs rather than hiring a pharmacist, because for them, they see that a pharmacist can do the same work as a farm tech, which is not true, of course. But for governors who want to minimize on their expenditures, they would rather employ a clinical officer than employ a doctor, because a doctor is expensive. But unlike doctors, medical doctors who have highly specialized and who have guarded the profession to a specific degree, pharmacy, unfortunately, we have not done that. And I can tell you, when I was doing my internship, when I used to go to the ward, I used to be asked, "Umekuja kufanya nini hapa?" Because people could not believe that a pharmacist is an integral part of the team that should be able to take care of a patient. And therefore, my entire internship for hospital was basically dispensing, and I didn't do much clinical until when I went back to do it. I had to go and say, no, I need to increase my skills, and that's why I went to do clinical pharmacy. And therefore, I think there's need for us pharmacists to see that where are we headed. And you can see, if you look at a newspaper today, you will see people are hiring farm techs. They are not hiring doctors. They're not hiring pharmacists. And I think Dr. Lokeno here, one of the things I'll ask you to comment is about what our account is really doing in making sure that our profession as pharmacists is respected and honored, so that we don't see these trends where people are hiring farm techs and they're leaving more competent cadre of people who are educated to take those positions. But what I can say, pharmacists, is what is the future for you guys? Forget about this future where you want to compete with farm techs in dispensing. You should forget about that. Think about research. Think about specializing in very specific areas of research like drugs, specialize in research on management, and these bigger things that are coming. So if you focus on that, then make sure once you have your degree, don't even be focusing to come and start competing here to dispense. Start thinking on how can I do research even on anti-cancer drugs, and go there and research on that area and specialize and be producing such like novelic interventions. Then another thing is diversity. I'm saying diversity because I mean diversify. You don't have to be only one area. You need to think on how can you. I want some of you to become the best pharmaceutical economists. I want you to become health economists. I want you to become some of you are the best pharmacognoscists who are going to look at pharmacognosy, traditional drugs, standardize them, prepare them, and make sure that we have alternative medicine. We should have some medicine which conventional medicine cannot work, but we should have pharmacognoscists who should be able to tell us, I can bring this concoction and it can work. And if we prove it, then you have cut a niche for yourself. We need toxicologists. People will focus on toxicology, poisoning, and such like things. So diversify. Like now I'm doing policy planning, and I'm managing now a grant. I'm not doing the clinical work. We don't have to be restricting ourselves. And this is where even the medics have become intelligent. They have gone everywhere, they are spreading, they are managing everything, and as a result, you cannot restrict them. But remember, the advantage of us as pharmacists is we can diversify more because we study about industrial, we study about community, we study about hospital, which makes us more diverse than anybody else. What we need is to bring that to reality. And another thing is we need to be universal, all right? Young people, listen to me. Don't think of Kenyan market. The people in New Zealand, they need pharmacists. The people in Australia, they need pharmacists. The people in Canada, in Europe, Norway, all these people need pharmacists. They need the people who are properly educated. Some of you should start now working towards that. You should start making sure that even as you are studying, as you graduate, you're preparing to leave this country to go and work everywhere. The people are leading that are our nurses. Look what where our nurses are. UK, we find our nurses are like this. Botswana, our nurses. Everywhere, even the US, our nurses are going there. Why can't you also be able to be universal? So you people, instead of finishing a degree after 5 years and come here to start arguing with the governor, some of you don't even care. And I'm sorry to mention, this is my country that some governors are too ignorant. They are even, some of them are even semi-illiterate. I'm sorry. Now you can't compete with them. Some of you are A students. You know that you are the best of the best. But now these fools, some of them, well, let me use that word fools, they are happy to frustrate you. They are happy to rule you and make sure mimi nilipata si yangu, wewe ukapata lakini sasa nani mdosi? Why can't you guys think of diversity of universal going elsewhere in this universe and in the globe. That is something that you should think. And of course, finally, pharmacy is evolving and has become a centerpiece for patient care. If you are not going to focus your care on a patient, if you are not going to be someone who's part of the care team, then I can tell you as colleagues that you are slowly but surely being negated even as time goes by. If you are not part of the table that is deciding the menu, be sure you are a part of that menu that is on that table. Otherwise, I want to tell you guys that ours is the most noble profession. I don't care the challenges it goes through. There is always a daybreak. There is always a bright day. Work hard in school, study hard, and even revolutionize the way you do. I expect when you go to do your internship, don't go to be behind the window. And that is something you do only for 1 month. The rest of the month, you should go to ICU, go to wards, go to clinics, and find out how the patients and make decisions on how patients should be taken care of. I remember when I was in Coast General, all the pharmacists interns who came there, I said, you are not going to be sitting in the window. That is for the farm techs and the attachment students. You are going to go to the wards and make real interventions and discuss therapy and ask questions. Why is this drug prescribed? What is the rationale? And by so you will learn and become an integral part. I remember when I went to Coast General, one of the most renowned pediatrician, Dr. Kapanga, some of you might know her, she's now retired. The first time I went there, she couldn't even, she couldn't even know what I was going to do there. But after some time, and I was a chief pharmacist, then after interacting with her, making some interventions, especially for TB patients and these chronic diseases, every time I'm not there, she will call me and ask me, Dr. Aguata, where are you? We are waiting for you before we start our ward round. And I think that is the future of pharmacy, whereby it will be no, we will not be looking at dispensers. We will be looking at a generation of professionals who are a part of the team that takes care of patients. So I think, colleagues, with those very many remarks and talking, I'm sure I've taken quite a while, as I never thought. I thought it would be very short. I want to end it here and give it back to you for the programmers. And if there are any questions, I think I'll be here to respond to them. Thank you so much.
Thank you so much, Dr. Bob. That was a fantastic presentation and we enjoyed it a lot. I think we can go to Dr. Lokeno before we end with the questions that were raised as our attendants registered for the meeting and any that will be raised in the chat box. So Dr. Lokeno, please feel free to take the floor.
Thank you very much. First of all, let me say thank you very much to my senior colleague, Dr. Aguata. That was quite a presentation, and personally, I've also learned quite a lot of things from the kind of work he does. And I'm sure all of you who are in attendance have also learned something that will, contribute to your career, even as you look forward to joining the field, joining some of us who are already in the field, so that together we can, participate in solving some of the challenges that we are currently experiencing in this era, some of which currently we are dealing with, which is COVID-19, and there's still so much to be done in this particular field. It's just something new, so we don't have experts yet. Everybody's trying to do something that will hopefully help in alleviating some of the problems that we are experiencing now with the COVID-19. So Dr. Bob, thank you very much. That was a beautiful presentation. And I realized initially when I was, when I introduced myself, the video was off. So I'm sorry for that. And hopefully now I'm visible. hopefully right now I am visible, and in the
Yes, Doc,
next.
you're visible. You're visible, Doc.
Yeah, thank you very much. So in the next 30 minutes or less, I hope to share with you some of the things, some of the things that I've prepared for us this evening. And as it was introduced earlier by the host, my name is Dr. Lokeno. I work here at Maralal in Samburu County, Samburu County Referral Hospital as a senior pharmacist. I am involved in the management of HIV as well, and TB, and even COVID-19. So I hope to share some of the things I've learned myself and some of the things that have been there and which we are trying to improve on. And hopefully this will help some of you to, or all of you in that matter, to see where we are coming from, where we are, and where we are headed. So I'll go right ahead and share my slide. So hopefully that will be visible. You let me know whether there will be any glitches, and so that I can correct that. So I understand Dr. Bob has covered HIV and COVID-19, and I was requested to just go over TB as one of the opportunistic infection in HIV/AIDS, and I intend to discuss TB in the context of COVID-19 and some of the challenges that are currently being experienced in the management of TB in light of COVID-19, and what can be done and what the role of pharmacists is in helping in the management of TB as an opportunistic infection, and OI in HIV/AIDS in particular. So how I intend to do this, I will briefly just mention what opportunistic infection are, and then I will discuss some of the opportunistic, just to give examples of some of the opportunistic infection in HIV and AIDS. And then I will go to discuss TB. I'll introduce TB briefly, and then discuss TB in the context of COVID-19. And then I'll also share some of the plans by the national government, specifically in the Department of TB, Leprosy and Lung Disease Division, the Ministry of Health, what they intend to do, what goals they have for the country with regards to tuberculosis. I will eventually wrap it up with sharing what you and I, as the pharmacists in the field, or you guys who are joining us in the field, what we can do in the management of TB now, and even in future when new challenges will come about. Like now we have COVID, so it's not the end. There will always be other pandemics in the future that will come, and how those will also affect the management of current, the management of TB at the moment. So I'll begin with just an definition of opportunistic infection. And as the word suggests, we all know in the common parlance, when you say something is opportunistic, we know it means, taking advantage of a situation where there is weakness, something comes up in that and monopolizes or take advantage of that situation. So with regards to infections and our health, opportunistic infections are illnesses usually that arise more frequently and more severely in people with weakened immune systems. And there are many things that actually, or many diseases or health states that results to weakened immune systems. HIV is one of those. We have the use of drugs. We know the immune suppressing drugs. We, malnourished states. And there are many other states that can result to one having weakened immune systems. And when one has a weakened immune system, then that means they are exposed to all manner of danger, health dangers, and therefore their bodies is left without defense against such intrusions. Since we are talking about HIV, Dr. Agwata has done a very excellent job in discussing HIV at length. So he has actually made my task a little bit less. So we know that HIV is a condition that actually leaves someone, if not managed, actually leaves someone with a weakened immune system. And so we realize that people living with HIV are at a greater risk, or at the greatest risk of contracting opportunistic infections. And opportunistic infections will come from, depending on what agent is actually causing the disease, we can actually classify them based on the agent that is responsible for the opportunistic infections. And I've just given a few classifications and a few examples. This list is not exhaustive, so this is just for the sake of this discussion. I will ask that you can refer further than this. This is just a guide for us having this discussion. So when the agent is bacterial, there are bacterial diseases that actually come about in people with weakened immune system. And I chose to list just TB because I'll be talking about TB at length. There are other conditions that actually come about, pneumonias that are caused by the typical bacteria. And then there are protozoal diseases that actually also take advantage of the weakened immune system. And I chose to mention toxoplasmosis because it's also common in HIV and AIDS. Fungal diseases, we have Pneumocystis, which Dr. Agwata also mentioned in his presentation, which is commonly known as PCP, but actually the name was changed to Girovesi pneumonia from Carini. But still, for the sake of discussion, we'll maintain the name PCP, that is Pneumocystis carinii pneumonia. And then we also have histoplasmosis and candidiasis. And then in viral diseases, we have cytomegalovirus, which is actually common in states where the HIV has progressed to what now you call AIDS. And then herpes simplex, varicella zoster, and then we have progressive multifocal leukoencephalopathy. So you will notice one thing about these opportunistic infections is that they are very common in HIV and AIDS. When HIV and AIDS is not properly managed, then this is usually likely to occur, and then they become a common feature in HIV AIDS. So that's why I specifically chose these ones, but there are many. This is not supposed to limit us to this. It's just a matter of, for the sake of having this discussion. So I'll go to tuberculosis. I'll mention what it is and a few things about TB, and then I'll progress from there. TB is an airborne disease, usually caused by, Mycobacterium tuberculosis. And I'm using the word usually because that is the most common agent. You realize that there are many species of mycobacteria, and TB, Mycobacterium tuberculosis, is one of those. There are others that some of them have actually been recognized or have been identified as causing and presenting as TB, the normal TB that is caused by Mycobacterium tuberculosis. So that's why I use the word usually, because of that particular exception in other situations. There are, as I mentioned, there are other species of Mycobacteria which also cause disease in humans. And not TB in this case, but just other diseases that are Mycobacteria in nature, depending on the species. And then while I mentioned that it's airborne, it has to be transmitted by inhalation. So the point of contact is when someone actually inhales or is in the vicinity of someone who has released an respiratory droplets or nuclei in the air, and then somebody inhales that. And depending on the size of the nuclei, there are those which are large enough not to go all the way into the alveoli. And there are others which are actually smaller nuclei, which when once inhaled, they find their way all the way to the alveoli. And then from there, they begin their process of multiplication and eventually causing disease. So I'll talk about why TB matters, why TB is a problem currently among people living with HIV/AIDS, just general public population as well. TB remains a public health problem globally. And this is shown by the fact that in statistic report that was released as of 2018, 10 million people were sick of TB, and 1.2 were HIV, who are HIV negative actually died, and an additional 251,000 deaths among HIV positive people who are living with HIV. And it has been estimated that a third of sub-Saharan population, and that's where Kenya also falls in, is infected with HIV. And out of this population, 5 to 15% risk getting sick. So you have people getting infected with HIV, and then there are those who will remain carriers, but then others will actually transition to having active disease, active TB. And so 5 to 15%. So you can actually see it's quite a large chunk of the population when you consider that a third of the population in sub-Saharan African countries is infected. And then Kenya contributes significantly to global burden of TB. Kenya is actually ranked among 22 countries globally that contribute to the highest burden of TB, multi-drug resistant TB, and TB in HIV settings. Just move on. In 2019, just last year alone, 147 people were sick from TB. And the problem is that despite having that number, only 86,358 people were diagnosed and treated. So that means a large, almost bigger than half the number of those who were infected last year up to now have not been reached with treatment and diagnosis. So they are still in the population. And the problem with that is that some of them will get sick and then they will begin transmitting the disease to others. And then that number will grow and it'll keep on growing like that if nothing will not be done about it. As of this year, TB is ranked as the 4th cause of deaths in Kenya. So you can actually see in terms of epidemiology, actually TB is a problem that should draw our attentions. And then treatment for TB, the duration is usually long, between 6 and 10 months. And that can actually go past a year, 12 months, depending on the complications, drug resistance, and those kind of things that actually usually happens. People defaulting treatment. So that can actually go past a year. And then I'll mention something to do with people living in HIV. I know Dr. Agwata also mentioned the figures there. So roughly 1.5 million people in Kenya are living with HIV. And that is also a large number, considering the fact that people living with HIV are at more risk of getting TB and transmitting it. And that actually complicates their status. Then I'll mention something to do with HIV again. 89% of people living with HIV know their status. And then 75% were on or are on ARVs, of which 82% are virally suppressed. And the reason why I'm putting these figures across is later on when we'll be looking at the strategies that have been put in place by the Ministry of Health in terms of containing the spread of TB. One of the key things in the management and containment of TB is identifying people who are at risk of TB, those who have contracted TB already, those who are not active, they have TB, but they're not sick with TB yet. And without knowing those numbers, then the fight against TB will not be won, because a lot of effort will be put in the wrong direction, and you'll still have a lot of people in the society who will be spreading TB from place to place, and that will actually hamper the progress that have been made so far. So Kenya has a target when it comes to the management of HIV of having 90% of people who are people who have been infected with HIV identified, and then that 90% of those transition to health facilities for management, and then 90% of that to be virally suppressed. So we realized, based on the reports that were released this year, the numbers, we missed that target. And again, I'm putting these figures across because these will help us to understand later on why that matters in terms of dealing with TB, because in the setting of HIV, because we mentioned earlier that HIV is a risk factor for contracting TB. And actually it becomes worse because then these people living with HIV have a weakened immune system, and they live in the societies, and so transmission can become very easy. And so more people will actually end up being infected, and then that can become a bigger problem if not managed properly. So I've also mentioned the fact that we have a new dynamic, which is COVID-19. And COVID-19, I'll mention how COVID-19 is a new challenge in the management of TB in the later slides. So if we look at TB and COVID-19, COVID-19 is still a very new disease with us, although a lot of research is currently going on. We already have the vaccine and all that, but there are still very limited studies that have been done in terms of trying to relate COVID-19 with TB and other diseases. So if you look at COVID-19 and TB, we still don't know so much about the interaction between the two diseases. What we just know is the fact that both of them affect the lungs. And other than that, the specific interactions are actually currently not so much known. So that presents a problem in management of TB, because we know that COVID-19, people who tend to have weakened immune systems, tend to suffer severely from COVID-19. And TB in itself is a disease that actually lowers immunity. And so that means that it exposes people to COVID-19. So COVID-19 appears to cause severe diseases in immunocompromised and people who have other comorbidities. And so TB itself can lower immunity, therefore putting patients who are TB patients at more risk of contracting COVID-19. And then there's a study that was done in South Africa recently that found out that anyone with a history of active TB has a 2 to 3 times risk of dying from COVID-19. Although the study was done there, the limiting thing about the study was that it was based on a very small population. So we can't really use that data to project and say exactly how the risk, how TB, what COVID-19 actually becomes in people with TB. So this was just to demonstrate that there is a likelihood that TB could make people, if it could be a very risk factor, a big risk factor in terms of making the prognosis of people who contract COVID-19 to be worse. And then we know that currently there's so much to do with containment measures for the spread of COVID-19. And one of the things about these containment measures is the fact that it tends to limit health-seeking behavior. And so you would find that if somebody is already in the community and manifesting symptoms of TB, and there's already restrictions in terms of movement from place to place, so that tends to interfere with case finding for TB, and then that, of course, would delay diagnosis. And for others who are already sick, currently on treatment for TB or on prophylaxis for TB, that would tend to interrupt that, because then you are limiting people from, the restriction tend to limit people from even visiting health centers, because as you can remember earlier in the year when there was even restrictions on movement, although sick people could be allowed to move, but then it was a bit difficult then for people to even seek health services. And so that in a way contributed to interruptions of services that actually people suffering from TB actually need. And then another problem that is that COVID-19 and TB tend to be similar in most instances. Both of them are respiratory diseases. They tend to have almost similar symptoms of cough, high fevers, general body weakness, loss of appetite, and those kind of things. And then also both of them tend to carry some stigma with it. So that's also something else that is a factor in terms of TB management. When somebody is looking at TB, that is something that they would want to consider. And then something else is that the current focus on COVID-19, therefore, could make it difficult to catch TB due to their similarities. So you realize that right now everybody is talking about COVID. At the county level, measures are simple. A lot of effort is simply put to ensure that the containment of COVID-19 is achieved. And so if someone was to present with symptoms that would be for TB, there's a high likelihood that that person would be thought of as having COVID-19. And so they will be isolated and put into isolation centers. And then before eventually the problem is identified, it will be some time longer than when the person actually presented to the facility for health services. So that actually makes it difficult for the current focus actually makes it difficult for new cases of TB to be identified, and that would actually delay diagnosis, and then treatment also will be delayed as a matter of the focus that we currently put on COVID-19. So I have just have here put a few similarities and then differences. And as I mentioned earlier, epidemiologically, both carry a significant burden. Currently, the numbers for COVID globally is about 72 million. And for TB, we mentioned that it's 10 million per year. So that is something that is a health problem. So both of them actually have a significant burden in terms of health. The difference with that regard is that TB, since we are still dealing with the COVID and it's still a very novel disease for us, TB therefore will still remain to have a very high burden, epidemiological burden, because of the 10 million per year people currently sick with TB. And then another similarity is that both of them are droplet transmission, and that means there has to be a respiratory droplet. For TB, it's airborne. For COVID-19, the virus is transmitted through contact and can get through into the body through mucosal surfaces. And when you look at the difference in terms of transmission, for COVID-19, transmission among people who tend to be asymptomatic, or people who are symptomatic, tend to be higher compared to TB, where when somebody is asymptomatic, they tend not to contribute significantly in terms of transmission actually. So for COVID-19, there tends to be that high level of transmission from person to person, even among those who are symptomatic, because of the nature, which is contact, as opposed to TB, which is airborne. So somebody has to actually begin manifesting symptoms of coughing and all that for them to be able to transmit when they are symptoms. So, and at the symptomatic level, you realize that for TB, with the bacteria in their bodies, they tend not to have that chronic cough that usually is typical of TB among those who are already having active TB. And then both tend to have fever, cough, and breathing difficulties. The only difference is that in TB, cough is productive, while for COVID-19, it has been identified that the cough is dry. So that is a point of difference. And then for similarities, again, both diseases tend to require a lot of surveillance. We all are aware of the current surveillance that has been put on COVID-19 with the daily updates, and any new case has to be reported to the Ministry of Health. There are specific contacts for that. And for TB as well, whenever there's a new case that is diagnosed, that case has to be reported also to the Ministry of Health. So, and then there's also the issue of contact tracing. So for both COVID-19 and TB, there's a lot of contact tracing that is done. So if somebody came in contact, if a new case is reported, then, and there are people who are in contact with that particular person, then they also have to be traced, and then tests done on them just to rule out the fact that they may have contracted the disease. The point of difference is that COVID-19 requires a daily surveillance, at least for now. Being a novel disease, a lot of efforts have been put to contain the disease. because of the fact that we don't know really much about this particular disease, and the best we can do is to ensure that we restrict its spread in the community. And then another similarity is that infection control is necessary in both cases. I'm sure we are all aware of the fact that there's a requirement to fumigate public places, hospitals, any other surface, any other area that is of potential in terms of harboring the, in terms of being an area that can actually contribute to the transmission of the disease. So COVID-19 and TB, actually, there are infection control protocols that have been put in place to ensure that the spread is halted. So that is another area of similarity between the two diseases. Before I go to just a few terms that are usually used with the TB, I want us to understand the fact that the strategy for management and prevention of TB includes the fact that there has to be constant aggressive approach in terms of finding new cases of TB, and then linking all those new cases to health facilities for treatment, and then monitoring the treatment until finally the patient is cured. So you realize the fact that COVID-19 is bringing a new challenge in the sense that, number one, as I mentioned, we have the new protocols that have been put in place to restrict transmission of COVID-19. And some of those restrictions have actually contributed significantly in terms of restricting people from seeking health. So the health-seeking behavior is has been interrupted in a way by the restrictions that have been put there. Second thing is the fact that the similarities that these two diseases have, one of which is the stigma. So you'd find that even when people who ought to be visiting health facilities for health checkups, and when they develop symptoms that would be those for TB, because of the fact that right now we are dealing with COVID-19, and the symptoms tend to be similar to those of those of TB. So you find that people would want to shy away from presenting themselves to health facilities for fear of being stigmatized, that they have COVID, and being ostracized and being put in isolation facilities and all that. So you find even a case where the symptom was for COVID and somebody, for TB, and somebody was supposed to come to the hospital. The fact that now, there is that stigma with COVID-19, so people would rather stay away and shy away from hospitals. And that has greatly hampered the efforts to find new cases of TB. And then the fact that something else is the fact that those who have already developed active TB in the community would also not want to present themselves to the hospital because of stigma again. So you find they would think what they're suffering from or the symptoms they're manifesting is COVID-19, and so they would opt to stay away from health facilities, and that would actually hamper the delayed treatment for them. And of course, when treatment is delayed, and then TB can progress so quickly, and that can become another problem. And then something else that I mentioned at the beginning, of those who actually ought to be in health facilities for TB, you'd find that majority of them actually don't remain in those communities as as cases that have not been reached with diagnosis and treatment. So you'd find transmission of TB in the community would continue. And then with people living with HIV, that also actually complicates matters, because the fact that HIV is a risk factor, and we still have majority about 200,000 people, because if you look at it, 87% of 1.5 million, you remain with about 200,000 people in the community who have not been initiated on ART treatment. And so that means their viral loads will tend to go higher and higher, and therefore the immune system will tend to be weaker and weaker, and that will expose them to TB. So you realize the fact that TB in that case will actually accelerate, and that will add to the numbers of those who those who are already on TB but have not been receiving treatment so far. So I wanted to mention those factors so that when we move forward, we'll actually see where you and I, or you who is aspiring to become a pharmacist and joining us in the field, will the role that you would actually want, you'll actually play in the field. So latent TB, this is a term that is used to describe a case or a person who is has the bacteria in the body, but the body immune system is able to keep the bacteria, from multiplying and damaging organs in the body. So these people tend not to be transmitters of TB, so they just be carriers in the community. And then you have active TB. So active TB is a case where somebody who had TB in their bodies, but their bodies was able to keep the immunity, the virus, the bacteria from multiplying and causing damage in the body. Suddenly they become active. So the bacteria become active and begin multiplying, and then they begin having these the symptoms that are usually typical of TB. So those kind of cases would be active TB, and these are the people who now be able to transmit the disease to other people. And then you'll have what you call bacteriologically confirmed TB case. So when it comes to diagnosis, you can either have bacteriologically confirmed TB or clinically diagnosed TB. And the difference is the fact that for bacteriologically confirmed TB case, you'll have to have a biological specimen, which will be tested by any of the methods like smear microscopy or culture or gene experts and other rapid tests. And once these methods have confirmed that there's actually bacteria in the specimen, then that case becomes bacteriologically confirmed TB case. For clinical diagnosed TB, that refers to diagnosis that is made by a clinician based on the symptoms and other methods other than the bacteria having a biological specimen taken and then tested for bacteria. So if they used X-rays or any other form of imaging that would suggest presence of TB in the body, then that kind of diagnosis would be called clinical diagnosed TB. And then bacteriologically confirmed TB case can actually also be further classified into, depending on the anatomical site. So you can actually have pulmonary TB, which is TB that is confined to the parenchyma of the lungs. And anything that is not, any TB that is not in the parenchyma of the lungs is what you'd call extrapulmonary TB. And then you can also classify it based on the history of previous treatment. So you can actually you can have a new patient or a previously treated patient. So a new patient would be someone who has been either exposed to any of the TB drugs for less than a month, or they actually been known not to have been exposed to any TB drug, while a previously treated patient would be someone who would be exposed to TB drugs for a period of more than 1 month. And then also you can have them classified based on the HIV status. So you can have an HIV positive patient or an HIV negative patient, or also a non-HIV status. So depending on the status of HIV, then a patient can actually be classified accordingly. Although it's a requirement that all patients, all people who living with HIV should have their TB status known, and also vice versa. Patients who are been diagnosed with TB also need to have their HIV status also known. So you'll find that usually the unknown HIV status patient is practically almost always not there, unless in very rare cases. Then also you can classify them based on the drug resistance, and you can have monoresistance, polydrug resistance, multidrug resistance, extensive resistance, and rifampicin resistance. Monoresistance would be a resistance to only one of the first line treatment of TB, but of course, except isoniazid and rifampicin. And then when you look at polydrug resistance, is where you have resistance to more than one of the first line drugs, but leaving out rifampicin and isoniazid. And then multi-drug resistance would be resistance to at least isoniazid and rifampicin. So you can actually have all the other resistance, that is monoresistance, polydrug resistance plus isoniazid and rifampicin. And then extensive drug resistance would be resistance to second lines like the fluoroquinolones and at least one of the second line injectables like capreomycin, amikacin, or kanamycin. So that is what we call the X drug resistant TB. And it's important to understand some of these, especially the resistance of Mycobacterium to TB drugs, because this becomes very important in terms of informing the course of management and treatment that should be recommended in those kind of situations. And pharmacists will actually come in very handy in terms of recommending options that would work for a particular patient when resistance is confirmed. So that's why I thought it would be important to share some of these terms that are used when describing resistance to TB drugs, because then that becomes also a key role for a pharmacist to play in terms of choosing regimens that would work. Going to the national strategy for ending TB, Dr. Agwata mentioned that the Ministry of Health has a policy for, or has a vision for ending malaria, TB, and HIV in the country. And the current timeline is that by the year 2030, there should be at least 90 to 99% reduction. So I've actually put this on here as 0 incident rate for TB and 100% cure rates as some of the strategies that the ministries, the goals that the ministry is looking forward to in order to eventually declare Kenya free from TB, HIV, and malaria, as Dr. Agwata had mentioned. But for TB specifically, we'll be looking at 0 incidence rate and 100% cure rates. So I'll go ahead and mention the roles of the pharmacist. So far, we've seen that TB, COVID-19 presents some new dynamics in terms of management of TB. and that is in the areas of identifying new cases, disruption of treatment, the fact that there are possible drug interactions that will actually come along. So I'll be discussing a few areas where you as a pharmacist will actually have a role to play in terms of reducing the burden of TB in light of the national goal of ending TB by the year 2030. So first of all, with regards to HIV, as a pharmacist, and as I'm thankful because Dr. Gwata mentioned that the roles of pharmacists are now changing, and it's now more of patient-centered, and that means the pharmacist has to spend a lot of time with the patient in the wards, or even at the pharmacy level, and looking at their treatments and giving inputs on how that can be improved. And so you realize that in the case of HIV, one of the areas which the pharmacist can actually play a role is ensuring that all people living with HIV that is all eligible people living with HIV on TB prophylaxis. And this will play a key role in terms of ensuring that the 5 to 15% of people who are likely to transition to active TB would actually not go to that level. So if someone had latent TB, then when they put on prophylaxis, that will actually help them to not to transition to active TB, and that will protect the rest of the people who are healthy from contracting TB. So a pharmacist can actually play a key role in terms of ensuring that all those who are eligible to be on TB prophylaxis should actually be on TB prophylaxis. And then another area is the fact that treatment, as I mentioned, treatment for TB usually takes a minimum of 8 months, and it can go even past 1 year. And the problem with that is that no one really likes taking medicine for a very long period of time. And so definitely adherence will become a problem. And if patients will not complete their treatment, then that will hamper the treatment of TB greatly, and there will be complications. So the pharmacist can actually play a key role in ensuring that patients adhere to their treatment, to see that they actually begin their treatment and they go the whole course until the end, where which is desirable. So pharmacists have actually a key role to play there. And third thing is the management of adverse drug reactions. We know that TB drugs and HIV drugs have a lot of interactions that are already known. And as a pharmacist, you can actually play a key role in terms of helping the rest of the team, either in the wards or even at the pharmacy level in the hospitals, to identify some of these drug interactions and play a key role in terms of pointing them out and helping the other team in terms of selecting now drugs or intervening appropriately to manage those drug interactions. Something else is, so that is drug interaction. Then adverse reactions, of course, there are those that are known, that are like peripheral neuropathies with isoniazid. And as a pharmacist, you can actually play a key role in terms of helping patients to understand that some of these reactions can actually occur and managing them accordingly as specified in the guidelines. And that will go a long way in terms of helping in adherence and patients actually completing their treatment. And then currently with the issues of COVID-19, remember, we are looking at all these interventions in light of COVID-19, the fact that COVID has its own dynamics that has brought into the picture. And so one of which is you want to ensure that patients who are currently being treated for TB are protected as much as possible from contracting COVID-19, because then remember, we don't know what COVID-19 could actually do in a setting where there's a TB. So you, as a pharmacist, you want to play a key role in terms of ensuring that patients who are on TB are protected as much as possible from contracting COVID-19, because that will be an extra burden to them and will impair the progress of treatment of TB in those particular patients. So as a pharmacist, you can actually be proactive in coming up or implementing infection control protocols set by the Ministry of Health in every setting, in the wards, in outpatient facilities and everywhere, so that you ensure that there's a limited transmission of risk of transmission of COVID-19 to such kind of patients who are already immunocompromised and on TB. Then management of unnecessary polypharmacy. We know that right now with COVID-19, there are so many drugs that are actually tried as much as possible to manage patients who are COVID-19 positive, who are already COVID-19. And so if you happen to have a patient who is HIV positive, suffering from TB, and then contracting COVID-19, so that becomes an area where unnecessary polypharmacy could actually come in. And as a pharmacist, you have a key role to play in terms of ensuring that you point out areas where drugs that have been recommended are actually not necessary. And then you help the patient in terms of optimizing their treatment to achieve the best outcomes possible for them. And then management of refills for patients who, like those who are on prophylaxis and those who are actually on treatment. Because again, you realize COVID-19 has actually made it difficult for some patients to actually access health facilities because of the factors that I mentioned previously. And as a pharmacist who will be in that position of helping patients actually manage their refills, to see that you limit them coming to the hospitals by providing them with longer prescriptions for their medicines. And that way they will be at lower risk of coming to facilities where the transmission of COVID is possibly higher than in the community. So those are some of the areas or the roles a pharmacist could actually play in the management of TB and reducing the burden of TB. And this is just to help us here. It's not exhaustive. And so further studies, I've actually provided some references for further studies, and hopefully that will be of help. So thank you very much.
Thank you so much for the wonderful presentation, Dr. Lokeno. And for the participants, I'm sure that there will be a link posted on the chat box. Please ensure you fill the feedback form to get your certificates. Now we move to the question and answer session, which is going to be quick. So I'll start with Dr. Lokeno, now that you're the one who's presented last. So there was a question raised on the if it is possible to have false positive cases of COVID in TB patients because of the similarity that comes in with their symptoms. Is it possible to confuse the two without proper diagnosis, and what can be done to, ensure that there is no confusion now that TB patients and COVID patients are both respiratory related? You're muted, sir. I can't hear you.
So if I got your question, you're asking whether there's a possibility of having a false positive COVID-19 test in
well, they both have
in TB patients.
in
Yes.
a way, you mentioned that they have similar symptoms of coughing and fatigue and all those symptoms. So normally it takes a while for diagnosis results to come through. So is it possible to have TB patients who are being treated as COVID patients in a false positive kind of sense?
Usually what happens with the treatment for, the diagnosis for TB is currently we do have tests which are actually very rapid, and within 2 hours you're able to know whether somebody is TB positive or not. So one of the tests that is currently used frequently is a gene expert test, which is able to tell us whether somebody has TB bacteria in their body and whether the bacteria is sensitive to rifampicin. So you find the fact that that test comes out in 2 hours or so kind of eliminates the risk of having somebody being treated for TB while they are COVID-19 patients. So I think that alone would eliminate the possibility of that kind of scenario arising.
Okay, and then in terms of opportunistic infections and HIV, we know that it is very prevalent in HIV patients to get infections due to their immunosuppressed state. So is there a status or a situation whereby there is a sort of parallel between opportunistic infection management and HIV management, such as one has to be stopped for the other to take precedence? Or I hope my question is clear. Either with TB and HIV or other infections.
Probably let me comment on TB as an example. You'll realize that once a patient has been diagnosed with TB, because usually you'd find in setting facilities, you'll realize that the patient would be brought into the wards. They are very sick, and then a diagnosis is made, and they're found to be suffering from TB. The next thing that would be done is a test for HIV, and most often than not, those patients will be HIV positive. Those who present to the in-setting facilities from TB. The current guidelines recommend that within 2 weeks of that patient actually being able to tolerate TB treatment, then they can be started immediately on antiretroviral therapy. For those who present with other OIs like cryptococcosis, the management usually is that first of all, the ART can be delayed until that patient is stable enough to begin taking them. So usually there's a period that will lapse before the patient can actually be initiated on ARVs. So, but for TB, usually it depends on how fast or how quick the patient is able to tolerate the treatment for TB. And once they're able to do that, then they can be started immediately on ARVs. But for cryptococcosis, for instance, the treatment usually have to be deferred, because the treatment for cryptococcosis is a bit also lengthy. They have to take some time. And so the patient has to be, first of all, treated for cryptococcosis before now they can be initiated on ARVs. For others like herpes simplex or candidiasis and all these others, treatment can actually be concurrent, while the patient could be taking ARVs at the same time taking these other medications. So it depends on what exactly is being managed.
Okay, thank you. Last question. Dr. Agwata had raised a question in terms of pharmacist roles in hospitals at the county level. So is it the situation still similar now as it used to be, where we still have that sort of conflict in terms of allowing pharmacists to take up the actual roles in the hospital as opposed to pharmtechs, because we know that we have a lot to offer in terms of patient care and being part of the healthcare management team?
Thank you for that question. You know, the roles of a pharmacist have actually evolved from the traditional roles of serving patients from the counter in the outpatient facility to now being patient-centered. And the pharmacist is now expected to participate actively in the management of patients in both the in-setting in the wards and outpatient facilities. So the attitude that was there previously that Dr. Agwata mentioned during his days when, you know, a pharmacist would walk into a ward and everybody else would be surprised or look, you know, like ask question like, what is a pharmacist coming to do in the ward? That now has is actually no longer there. So the pharmacist now has more liberties in terms of you know, walking into a ward and you know, perusing a patient file and making their own notes when they see something is not adding up, and then together with the attending physicians and the rest of the team, you know, they can look at that particular issue and then provide, the pharmacist can actually provide a solution in that particular setting. So that has actually changed. I would say that has changed, although in some settings that, you know, there is, of course, some habits, you know, they say old habits die hard. So you'll find for those who were there during those days, like in Dr. Agwata, you find there are still those physicians who would, especially consultants, who would still not regard pharmacists as much in terms of playing a key role in the management of patient. But then as a pharmacist, you'd actually have to know your role and then act on it, because eventually what people want to see is the kind of intervention that you're actually bringing in the management of a patient. And so when they see that a pharmacist is actually participating more and, you know, intervening in ways that no one else could in terms of optimizing their treatment in every possible way, then everybody tends to appreciate that, and actually you'll be welcomed and even more sought after in terms of providing guidance in what to do with regards to patient treatment and, you know, pharmacotherapy.
Thank you so much, Dr. Lokeno, for the awesome answers and the fantastic presentation. I now move to Dr. Agwata. I still see that he's with us. And for him, I have two questions. I hope you can hear me, Dr. Agwata.
Yes, I can hear you. I can hear you.
Okay, sir. So for the first question, during this pandemic, we have had a sort of drift or shift in terms of distribution of health services and medication to patients because of the stigma that has been raised in the presentation, as well as the fear of contracting the virus and isolation, among other measures taken to curb the spread. So has it affected management of HIV/AIDS in any way, considering these are patients who are constantly on medication and they actually need to get their supply from healthcare centers and facilities? So has there been any impact on the ability of HIV/AIDS patients to get the drugs they need? And can it have any consequences on the adherence and trend we're seeing in terms of fantastic management and reduced viral load in patients?
Allow me, please, before I answer that question. There's something Dr. Lokena has mentioned, which I think I wanted to put emphasis. Then I go to the question you've asked. One of the things that we faced is the question of defining what really our role is. But one of the things also we found out is that increasingly, some of our colleagues were becoming very, let me use the word lazy, intellectually. You know, there's something I call intellectual laziness, and I want you guys to start using it, that don't be an intellectual lazy person. And I want to give an example here, which is not a mockery. When you find somebody like a pharmacist, you are supposed to go do masters, then you tell people you want to go and do health system management. Something even primary school teachers do, something even anybody can do. And then you say yourself you've done masters, just because you want to be intellectually lazy so that you come back here, and because people will not find you a good role, they put you to be a pharmacist in charge in a small hospital called, let me give an example, Kiamber Health Center. You know, that's when you have lost focus in life. And Dr. Lukena, you can agree with me, some of our colleagues, especially those who have been lazy, they have been comfortable. They want to do easy things, not because they want to have an impact, but because they want to have a promotion in the job group. And then they end up just becoming just another notoriety. Those people have become an hindrance. And I'm asking the young people who are coming up, don't come to be intellectually lazy. Some of you want to come because you realize dispensing is the easiest. You do from morning up to 4 or to 3 in some places, and you are off to go and enjoy beer, you are off to go and do other things, then you don't want to involve yourself in serious work that will make an impact. And as such, you find that very serious people who are intellectuals in that facility don't recognize you. As an intellectual giant, you need to make your own impact in that facility. Be where big decisions are made, make your contributions, make mistakes, learn from those mistakes. And that's how actually we can be able to prove ourselves. And something Dr. Lokeno said, very important. When you come to the table, what do you bring to the table? That's very important. I remember I want to give a case for me. When I went to Coast General, the first time I was called the ward round, the consultant there didn't even know that I'm a consultant pharmacist, didn't know that I'm the chief pharmacist of the hospital. He mocked me very badly, only to realize that when we were sitting in the consultants forum that I'm a consultant. Later, when I went there and they asked me a question, and I was able to make a contribution, then they realized this is a serious person. So when I example, like in the pediatrics, one of the problems was under dosing of TB medications. And because the way the drugs are prepared, some fixed doses have a lower dosage of specific drugs. So you have to look for the specific drug and add to it to make the required dose. I did that. The kid had been receiving anti-TBs for almost a week. The temperatures were not going down. When I looked, I said, I think the dose is not right. I adjusted the dose, the kit was given. By tomorrow morning, the temperature has gone down. From that day onwards, even the medical doctor interns, they were told, don't make any TB dosage without Dr. Bob. Or if you are far, make a call to him. So the impact you have is, do you want to be an intellectual giant and sit in the table of men and women? Or you just want to be a dwarf, you go there, you become comfortable, you are paid good money, you are lazy in this community because it's the only sub-county hospital, you are one of the respected people, named Daktari, and then you walk around here, then 5 years down the line, you want to do health system management and come and start bragging and they get job B and they get good salary. Or you want to be somebody who makes serious decisions and who's willing to work long and hard. So I wanted to emphasize what Dr. Ikeno said. Please make sure that you stand on the table. There'll be mockery, there'll be despise, but be there, be insistent, use your brain, learn from them what you don't know, be open, say, let me refer that one, let me check that one, and then you'll be somebody who will make an impact. So I think we are the one who will chart our future. Nobody will chart, and nothing is given, everything is taken. Go to that ward, sit there, do work, refuse to sit behind the window and just walk out after 12, and then I think the impact will be felt. It starts one person and it snowballs. Now, coming to the question you asked about effects of HIV or COVID on HIV services, I want to say that the services were not very much affected. Why? Number one, because we give our patients a 3 month drug, period. So by the time that COVID was coming, our patients, most of them, I can say 90%, were having drugs. That was why there was no much impact. Secondly, we foresaw that and we realized that there's going to be a problem. And the problem is what will happen with travel cessation? What will happen with the travel restrictions? I mean, so we communicated to all the CASCOs, that is the county HIV and STI coordinators. We told them, please communicate to facilities that anybody who has been caught by the travel restriction, wherever they want to access drugs, they can be able to access. And by so doing, we made sure that for those ones whose refills were due, will be able to access drugs from any place within the Republic, any facility, so long as they were able to prove, especially using their cards or using the drugs that they use and be able to communicate. So by and large, most of our patients were not affected. However, cases never miss of those who are affected. And of course, mitigations were from case to case, but largely they were not. But another thing that really affected us is the is the commodity security. We know that most of our commodities come from India. And I think some of you young guys, pharmacists who are coming up, why can't you guys think about starting your own manufacturing plant here in this country? All right. We don't have anybody who's manufacturing. And this is something you can come, you write to the bank, you go there, you sit, you discuss, and they can fund that. And the government can actually be able to facilitate, not only for ARVs, but all of these drugs. So when India closed down because of COVID, actually some of our commodities were not able to come. Even some of them that we had put orders were delayed. So I think that was the effect, and it affected the service such that instead of the 3-monthly refills that we give, we were now giving a monthly refill. So that was, I say, the effects on the HIV, of COVID on the HIV services. I think what else was it? Anything else that was on that question, madam? I think
no, you've answered that question very well. One final question. In the management of COVID-19, you mentioned that there is use of respirators because most of these patients present with low oxygen saturation levels and require oxygen replacement. So due to the acute respiratory distress syndrome that some of them have, is there a possibility of lung damage? Because we have seen in clinical pharmacy before that use of respirators for a long period of time can result in lung damage and even affect subsequent lung function because of fibrosis and inflammation. So is it possible that some of these COVID-19 patients can end up with damage to their respiratory system that they might have to live with and have impaired respiratory function after COVID-19?
Definitely. I want to say that apart from just the effect of respirators, COVID itself, you see, we call it the etiology. If you look at the etiology of the virus, it has one of the things it targets is organs. And what happens is that there is a lot of accumulation of thick fluids, especially in the lower lobes of the lung. Thick mucosa, it is so thick, and actually it closes up. And one of the things that scientists are speculating is that it causes lung infection or lung infarcts, which is basically some parts of the lung will end up not being operational, even if you recover from the disease. Some parts of the lung might be dead. So there is an effect, and not only from respirators, but by the virus itself, it causes that. But what I can say is, if you look at the advantage of using the respirators versus the disadvantage, I think the advantage outweighs the disadvantage. So much as this might be a reason, the fact that the virus itself can cause that gives us the leeway to use it to save life. Then we can deal with the other effects later. So, and I think that's one reason why some proponents were saying we should be using steroids, because there is a lot of inflammation that takes place to lower that inflammation. But really, you know, from studies and from limited, experiments, they were not able to establish basically that the benefit is big enough. And I think that's why there was a discouragement of use of steroids, because it also had other side effects apart from that. Yeah.
From my end, thank you very much to the speakers for the enormous amount of advice they have given us and the knowledge that they have shared with us today. So as we wind up, I would like to invite Bill, who's the KEPhSA president this mandate, to give the closing remarks and the vote of thanks. Thank you very much.
Thank you very much, Tiffany. Good evening to everyone. Our speakers, Dr. Lukeno, Dr. Guata, we've had an amazing session with you and we are getting responses as from now. To the questions that have been asked and time has cut us short, we ask you to join the Google groups. The answers will be given there by the speakers. We also could like everyone who has joined and attended the meeting to please fill in the feedback forms so that it can help better ourselves in the future events and any other activity that you'll engage in. I want to thank everyone and most especially those who found time out of their busy schedule to come and attend. So we'll also have your certificate for you guys printed and no, not printed in soft copy form. And Manyala will work on that, is MPO. So I just want to thank all of you, both the two doctors also, and thank you for your time. Thank you for accepting to come and share your knowledge with us. It's been insightful, and I pray that you have a nice day and a nice week ahead. Thank you.
Thank you so much.
Tiffany. Tiffany, can you close the meeting?
Yes, I'm giving time for participants to fill in the forms. I hope you can see the link below, but from my understanding, it will be shared in your emails. But if you don't have it, please feel free to text any of the executive committee members here to get it and ensure you fill it to get your certificates. And as Bill said, thank you for attending. So I'll invite Alvin to pray and then we can leave the meeting.
Okay, let's believe and pray. Father, in the mighty name of Jesus, we thank you, God, for the meeting we have had. We thank you, God, for each and everything, God, that you have learned, oh God. And we pray, Jehovah Nissi, my Lord, that as we're going, Lord, to live from here, we ask Jesus for your blessing, oh God, that whatever, Lord, you have learned, oh Jesus, you may help us, oh God, as young pharmacists, oh God, to impact upon our community, oh Jesus, my Father. We thank you, God, and we glorify your holy name, oh Jesus. And what, Lord, I've not prayed for, may the Holy Spirit intercede for me. In Jesus' name, I pray and believe. Amen.
Thank you, Alvin. You can leave the meeting at your pleasure.